How effective are current anticoagulation therapies for VTE management in patients without cancer? In this episode of Critical Conversations on Venous Thromboembolism, a MasterClass series on DVT and PE, Drs. Cohen and Doddleswig examine evidence-based recommendations for VTE management in patients without cancer and discuss the duration of anticoagulation therapy for these individuals. Access the full series and complete the post-test for credit at peerview.com/HBR860.
Thanks for tuning in to episode 3, Anticoagulation, when to use it, with what, and for how long. So to guide our discussion on the treatment of non-cancer related VTE, let's have a look at another case. This is a 55-year-old man with a history of chronic kidney disease who developed painful swelling of his right leg. He's slightly hypertensive, his heart rate is 91, but his eGFR is 43 mils per minute, which means he's got a form of moderate renal impairment. He's receiving a statin, a beta blocker, an ARB, and low-dose aspirin, and the ultrasound reveals a proximal DVT extending to the femoral vein. What are the choices we have for this man, Steve?
Yeah, so I like to go back to what we've seen most recently. In 2021, there was the second update from the guidelines that were originally put forward, and they do stay and they adhere to following the patient chronologically. So that means an initiation, which it goes from a time period of 5 to 21 days. Then it goes to primary treatment for the 3 to 6 month phase, and then extended or secondary prevention. And to start, it's worth noting that whether you're looking for an oral lead-in, that could be with either rivaroxaban or apixaban, always BID on the initiation period of time. And rivaroxaban is 15 milligrams BID for 21 days. Folks need to be mindful that it has to be with a meal. You need to take it with a meal to have good bioavailability, whereby with apixaban, that's 10 milligrams twice a day for 7 days, independent of any meal. And then there's always options of parenteral lead-in, which could be with an enoxaparin or an unfractionated heparin type of moiety. And then we transition to some primary treatment options. When do you use oral lead-in for your initial VTE treatment?
I use it actually for the majority of my patients, Steve. There are some patients I give parenteral therapy for, say patients with intermediate or high-risk PE. I might give some parenteral therapy for a day or two. But the majority of patients I start on oral therapy and continue it throughout. And it seems to be very effective, as we saw in the clinical trials. What about you, Steve? Something similar?
Yeah, very similar. And the only time I'm these days using parenteral is if I'm having someone who had bariatric type surgery and I'd have a concern, or another patient that I'm concerned about their GI absorption, or if I think they might have a plight that might require catheter-directed thrombolysis or some other intervention, then I'll use a parenteral there. But really, it's really the small minority, almost always oral these days.
Yeah, very much the same. And what do you think determines the dose and duration of the anticoagulant therapy in these initial phases anyway?
Yeah, in the initial phases, most of these folks, I'm giving the therapeutic dosing. I'm not going to be thinking about making the dose adjustment down unless it's a very unique circumstance. And so I'm going to replicate the clinical trials. And so whether you're looking at Einstein with rivaroxaban or Amplify with apixaban, in that regard, I'll tend to go to 6 months. Even though the range, as you saw, was 3 to 6 months, I tend to go longer unless there's a particular concern on the bleeding aspect.
What about changing the dose or changing the drug for eGFR? In my view, we don't change it very much.
And one other point I would mention is that many primary care and other think about the age, body weight, and creatinine. You have 2 to 3 for atrial fibrillation dose adjustment for apixaban. That is not the case with VTE. We do not have a renal dosing adjustment is what I would offer.
So what if Michael had, say, a history of DVT? So he's now got a recurrent, unprovoked VTE, and now he's got a history of rheumatoid arthritis. He's on some disease-modifying agent, methotrexate, but he's still on all the other treatments that we've been talking about. How would that change our approach, Steve? What modifiable risk factors for bleeding can be identified? Could you just list some of them for me?
Yes, for me, I would always reflect on and re-look at the medication list and whether someone's on an antiplatelet here, aspirin, or perhaps the person's on an NSAID. This would be the time to really think about removing, because those are notable risk factors on the hemorrhagic side, the bleeding side. And we'll look at the has-bled in that regard now, even on the venous side, not just on the arterial side. And as far as which anticoagulation strategy has the lowest risk of bleeding, I think we touched upon that. Do you have any additional thoughts around that, Andrew?
I think it's very clear that the DOACs have a reduced risk of bleeding compared to vitamin K antagonists, and I think we saw excellent results with apixaban, with a 69% reduction in bleeding and about a 40% reduction with rivaroxaban in the two studies. Also, some reductions were seen with edoxaban and dabigatran. So I think it's the DOAC's the answer. And I think that this patient has now ongoing risk factors. So we have to choose something that perhaps we could potentially alter the dose depending on the disease state. So when someone has something like rheumatoid arthritis, that makes me want to continue the therapy a bit longer because it's ongoing risk. But rheumatoid arthritis sometimes flares up and you need like probably a bit more anticoagulant, and sometimes it's quiescent. And in that situation, I think apixaban and rivaroxaban are useful because you can alter the intensity of the anticoagulation.
Yeah, I think those are excellent points, Andrew. And as you highlight, this is a very dynamic condition. Many of these are. And here being an extreme inflammatory condition potentially, and that puts folks at very high risk. So that may be a time where even if you were contemplating a reduction, not so much on a duration, but a reduction, this may be a time that you choose not to do that.
Yeah, and you've mentioned adjusting the medications already, but do you think you might add something in? I mean, if you're worried about them having GI bleeding, would you add in a PPI inhibitor? You know, someone with rheumatoid arthritis who's got some drugs that might affect the integrity of the GI tract. I mean, what are your thoughts on that?
Yeah, that's something that needs additional study for sure to pick it up. So I wouldn't say uniformly we would do that for all these patients, but it's worth thinking through it. How about your approach?
Yeah, it'd certainly treat indigestion anyway, but as you say, not routinely. So if we come to the extent of therapy, we know from the CHEST and ASH guidelines that the duration of therapy is recommended for first provoked VTE, say someone with a transient factor that goes away, just 3 months or 3 to 6 months. But for an unprovoked VTE, we think about extending treatment, and same for recurrences and cancer. So there are lots of patients that we're extending therapy. Are you using more long-term or extended anticoagulation in your patients, Steve?
We are. I've been delighted to see the different guidelines come together and be aligned. That wasn't always the case. So that is absolutely our trend. And most of the folks, we might make some dose adjustments, not all. And maybe we should talk about some of the people that will keep on a higher dose. But how about you? What's some of your?
Yeah, well, I mean, I think we've got standard doses for many of the anticoagulants. We can't adjust them, particularly vitamin K antagonists and dabigatran and edoxaban. They're fixed doses. But for rivaroxaban, we can drop from 20 down to 10 milligrams, and from apixaban, we can drop from 5 down to 2.5 BID. And I find that very useful because I think if a patient has got an ongoing persistent risk factor, maybe obesity or chronic renal impairment or immobility, then I like to drop them down but keep them protected. But I think if someone's got a history of many recurrences, or there's neoplasia that's active and things like that, and we'll talk about cancer later, I like to keep them on the higher dose. So it's just no rhyme or reason, just a bit of, I hope, common sense, I hope, anyway.
No, I agree with you. And I only, there's some select populations that I'll keep them on a higher dose extended. And you alluded to some of them, probably just to add on, probably an antiphospholipid antibody syndrome patient, or maybe someone who has a particularly high hereditary thrombophilic state, but maybe plus or minus on those.
Yeah, and I do treat the triple positives, antiphospholipids, with vitamin K antagonists, but many of the double positives and single positives seem to manage very well on the DOACs. Okay.
Agreed.
Well, let's change Michael again, and now he's got a PE rather than a DVT. So he's got chest pain, and his CTPA shows a left upper lobe artery PE, and it extends from the lobar artery into the subsegmental branches. So a decent sized PE. So would that change things? Do you think it would change our management if he had this PE? Would my recommendations change? I don't think they would. I don't know about you, Steve, but I think if there's no signs of high risk PE and the patient's got an intermediate risk or low risk PE, I think I'd still ultimately manage them either initially or after a day or two of parenteral therapy with a DOAC therapy. What about you?
Yeah, I concur. I don't see high risk, blood pressure's okay here. I don't know his RV. I probably would get an echo get some additional inputs to help the guidance. But at this, from as presented here, I would stay the course as suggested.
Yeah, assuming that there's no right ventricular dysfunction or no evidence of cardiac enzyme elevation. Try and wrap this section up. We've covered some of the strategies for selecting and initiating anticoagulation treatment, and we've discussed briefly where you extend the therapy. And in our next episode, we're going to turn to really giving some attention to patient-centered care, how to discuss the benefits and limitations with your patients. So I look forward to that, Steve.
Same here, Andrew.
Thank you for listening to this podcast episode. Download the slides and practice aids for this episode and others at peerreview.com/HBR860. Be sure to listen to all 8 episodes in this MasterClass series and complete the post-test for instant credit at peerreview.com/HBR860. This activity is supported by an educational grant from the Bristol Myers Squibb and Pfizer Alliance.